So good evening. Thank you so much for coming to the Child Neurology Foundation's 2021 Patient Advocacy Summit. My name is Katie Henches, and I'm the Director of Programs for the Child Neurology Foundation. This is our inaugural Transition of Care Patient Advocacy Summit, and we believe that the patient voice and experience is an integral part of a successful transition from pediatric to adult care. This summit focuses on centering those voices and experiences, ensuring that young adults and those who support them have the knowledge, tools, and confidence to be able to make this process successful. In addition to this summit, CNF offers other transition of care resources, including a toolkit that is used to facilitate the many discussions required for a successful transition to adult care. These are available in English and Spanish. This and our other resources in transitions of care are available on our website, and the link to that area will be shared in the chat box. These resources and our summit would be impossible without our partners. We're able to put on a summit like this for free today, thanks to the generous support from our partners in transitions of care, which include Acadia, Biogen, Eisai, Genentech, Greenwich, and Zogenix. Thank you so much. We also hope that if this session resonates with you or that you find it helpful in advocating for yourself, that if you are able to think about making a donation to the Child Neurology Foundation. It's incredibly helpful in continuing our efforts to provide first-class programming and education like this summit to the full community for free. A link to the donation area will be shared in the chat box. All right, so on to our panel tonight entitled How Increasing Access to Transitions of Care Benefits All of Us. We're thrilled to have three esteemed panelists. First, we have Dr. Arava Muthan. She's the Assistant Professor in the Division of Pediatric Neurology at the Washington University School of Medicine. She leads the Arava Muthan Lab, which seeks to cure dystonia in people with cerebral palsy. She's very involved in the American Academy of Neurology Adults with Intellectual and Developmental Disabilities Neuro Consortium, where a large focus of their work is on creating better, more accessible transition of care for young adults. We also have Dr. Amari Sanchez-Logarty. She is an experienced licensed psychologist and strong support professional who works with young adults in nonprofit and community-centered industries. She's based in San Juan, Puerto Rico, and is skilled in identity development and formation. She's also oriented towards positive and goal-focused approaches. We also have Dr. Jose Postus, is a sports neurologist and neuroscientist who is based in New Orleans, Louisiana. He is the Neurology Residency Program Director at the Ochsner Health System and is part of the Ochsner Concussion Management Program and the Ochsner Headache Center. He's also the chair of the American Academy of Neurology, underrepresented in neurology section, and is heavily involved in the inclusion efforts at the American Academy of Neurology. This panel is being moderated this evening by Amanda Joksha. Amanda is the treasurer at the International Foundation for CDKL5 Research and at Colorado Rare. She advocates on behalf of all people experiencing rare disease, including as a parent. So now that I've given my introduction, I'd like to pass it over to Amanda.
Good evening, everyone. We're really excited to have you all here and start this conversation. So with that being said, I'm going to go ahead and pass the mic over to Dr. Postus so he can tell us a little bit about what he's prepared.
All right, well, I'm certainly happy to be here speaking with you all today. I think that my perspective as an adult neurologist here, I would share that I am an adult neurologist primarily. I do see adolescents. I see primarily concussions and their sequelae, headache being number one. After that, I would say gaps in care that I see a lot, unfortunately, ends up being socioeconomic gaps and racial disparity gaps. I'll see the kid who's the star running back for their school. They get their head hit, on a Friday night game. They're about 15 years old, and then they'll see me for their concussion. And then I may see them a couple of years later with bad migraines, and I'll say, well, what happened? I saw you for your concussion, and we didn't get to come back and see each other again. And they'll say, well, I didn't think that this was something that you could help me with, or I didn't think that this was something I needed to report. I just wanted to get back in and play. So I think part of the advocacy that I try to do, especially after having seen a few of those early on in my career, is empowering and teaching my patients, especially the younger ones, that that warrior mentality of, don't complain, don't talk about it is not the right way to approach things. And especially the adolescent patients, opening up about your symptoms is not a sign of weakness. Telling not only your caregivers and adults, but telling your doctors, your athletic trainers, your teachers, how you're feeling and how this is negatively impacting your life is something that may make them feel vulnerable, may make them feel uncomfortable, but is an essential part of trying to achieve a better state of well-being. I think that's something that can feel overlooked. I think sometimes the patients themselves just want to stop feeling like they're sick, at least in the concussion world. I know there's a large spectrum of different disorders that are covered under child neurology, but certainly the one that I'm more familiar with ends up being concussion here. Another thing that I'll note, at least from my own interaction with patients, is modalities of care change as time goes on, and goals of care change as time goes on. I've had patients that start with me when they're 14, 15, 16, and they kind of graduate and go on to college, and the amount of medication they would need to treat their migraines, for example, would lessen because they're no longer sort of stuck in their social situation in the high school they've been in with the people that they've known for years and years, and now they get to go off to a college where they get to meet new people and perhaps get around more like-minded people who may be more accepting of who they are. So that psychosocial stressor drops, and that type of issue no longer sort of compels them to have as many migraines or other types of headaches as they are. So thinking holistically about my patients is something I try to do. But obviously this is something that I've learned the hard way through years and years of building rapport. And I'm blessed to be able to see them sort of progress over the years. Now I do kind of have an age cutoff of about age 14, so that I'm not kind of the end all be all here. I do try to rely on my colleagues as pediatricians and child neurologists, if they are trying to hand off patients of a younger age to me, to have a summary type of description of, where the patient has been, where they're going to, and what the next steps would be. I would say that from my perspective as an adult neurologist primarily, if there was a more, not universal, because it's not a one size fits all, but a more streamlined handoff process as these patients start to age from one age group to another, I think that might be quite helpful. Does anyone else on the panel have a thought on that type of thought or that type of process? Dr. Buma?
About handoffs in particular, Dr. Postus, streamlining handoffs?
Yes, from age groups to another. I mean, obviously there's the kind of, regular visit notes that we do, but should there be some sort of collaborative note between the child neurologist and the adult neurologist of like, hey, okay, we're going to formally have a patient, like an interdisciplinary team discussion from one timing to another?
Yeah, I mean, I think what you said just a few seconds ago about having it being difficult to have a one size fits all type rule is a really valid point. I think that in training, in child neurology training and in adult neurology training, we tend to see the idea of transitions as a specialty in and of itself. Like we had a wonderful attending, Claudio Melo de Guzma, who's published with Ann Tilton, a continuum on transitions of care. And he was our transitions guy, which I think it seems like we should all be transitions guys. So that idea of saying that there should be a standardized handoff, I think is a little bit difficult, because I think we should all be well-versed in transitions, adult and child neurologists. And that handoff is unique for the subspecialty, for the patient. And I think learning that skill is just like learning the skill of handing off between the day team and the night team on inpatient service and residency. The idea of transitions of care should be a clinical skill that's universally learned in residency. And that's something that I'm starting to get interested in more and more now that I'm an attending and outside of past residency now, it's very clear to me just how much of a pipeline problem transitions of care is and how much more we can invest with regards to medical education for physicians, both adult and pediatric neurology, and also for education for families and for the people affected by childhood onset neurologic diseases.
So I want to jump in here. So my work is mostly with transition as a skill for a caregiver and a patient. And talking about transitions, I like to remind families that transitions are a perfect opportunity for empowering the patient. So it's the perfect opportunity to get the patient to understand the condition, to understand their needs, to be able to communicate them, not only to their caregivers and their physicians, but to whoever they might need assistance from. My work focuses more on, once you have a diagnosis, it's not something you are, it's something you have. And understanding that helps the transition to move along. Another thing that we like to focus on is transition as a process. A lot of people get stuck, when we have a rare disease or a recurring condition, they get stuck in the pattern of constant change when it comes to care. And they forget that transitions we need to focus on as a process so that they get completed. Just like Dr. Postus mentioned at the beginning, they go to one appointment and then they disappear. And part of understanding a transition is that you need to follow up on the care so that you complete the transition and it's easier to follow up on that.
I love that idea, Dr. Sanchez, the idea of empowering the families through education about transition. And I think that's just so important. I think we think a lot about how am I going back to the handoff question that Dr. Postus raised, we talk about how am I going to hand off this information to the next physician caring for this patient, which is obviously valuable. But when you think about anticipatory guidance, which is a key feature of pediatric care, every well child check involves anticipatory guidance for what to expect for the next well child check. And I think transitions of care involves anticipatory guidance. So telling this young person, as you enter adulthood, the things that we've been dealing with might change to look like this. These are some other conditions that go along with your diagnosis that you may see. Here are some of the symptoms that go along with that. And if you see those symptoms, even if you're not under the care of a neurologist at that time, these are the symptoms that you need to be aware of that are likely to be associated with your diagnosis that should trigger, maybe I should go see a neurologist. So I think educating all parties, so child neurologists, adult neurologists, the patient, the person affected by the diagnosis, and the family can really fill gaps. So if you think about like the Swiss cheese model, nothing falls through the cracks there if everybody has that information. And it also really empowers families. I love that wording that you used. It is really empowering to have knowledge about your diagnosis and what the future may hold for you.
Yeah, and I appreciate that you defined anticipatory the process, because I think probably a lot of parents who are caretakers, we don't understand or hear those words or show up kind of demanding that from the people who don't know. So I really do think there's a huge place, even though child neurology is a big umbrella, I think there's a lot of room for caretakers and self-advocates to have some tools to start talking about these situations with their providers sooner rather than later.
It also helps. Dr. Posa mentioned earlier about accessibility issues that are often linked to social factors. So by talking about transitions as an empowerment tool, it also helps when maybe, the caregiver or the care physician you need is not near you, or, you don't have that particular specialist. So another thing that's very important to take into consideration is to be able to identify specialists that might not know everything you need them to know, but is willing to learn with you and go with you through that process. So it's important that the specialist understands your concerns and is able to acknowledge, I haven't worked with that, but we're going to get through it together and guide that transition, maybe, from their expertise, balancing out the concerns of a patient and their caregiver to the medical expertise, regardless of not being particularly what they need, especially when we're talking about rare disease or special rare conditions that might come up.
Yeah, I think we have to find a happy balance between, we have a whole lot of rare conditions now, and as advocates and caretakers, we can know a lot about a condition, but we can't expect every specialist we come to know everything about this stuff. So yeah, I think it's important for caretakers to also, and self-advocates to be able to learn with their providers and build that relationship. So I think to all the providers out there tonight, it's okay to not know and to be open about that. I think it builds a really good relationship moving forward.
I love that concept. Thank you for bringing that up. I mean, I'd say, frankly, the best transitions in care when I've had particularly complex patient histories come across my desk and things that I frankly don't know about. I'll walk in the room and I'll say, look, I don't know about your condition, but I'm willing to do my best. And I'm willing to try to grow with you into what your future is going to become. And even if I don't know exactly what's going on, I'll talk to the child neurologist who previously saw the patient, or I'll say, okay, well, your condition is more than just adult neurology. There may be some adult immunology. There may be some genetics here. There may be some immunology. There may be some other issues that need to go on, some cardiology, for example. And I'll try to get all the different specialists that this is now broken up into to try to coordinate care together, all under one banner, to try to help you out. And that's what I've told the patient. I think that the benefit there ends up being an understanding that, like, as physicians, as other healthcare professionals, we are human, and that we're willing to grow and learn all together, and that that I care, even though I don't. I'm not going to lie and say I know. Hey, I know everything about everything. Right? That's the last thing I want to try to come across as. That all being said, I mean, sometimes there are. I think it was mentioned a little earlier. There are ways that disease processes and conditions change over a lifetime. So what was true before may not be true as someone grows and ages, and certainly as conditions have newer treatments that come out, those things may change as time goes on, especially with all the new genetic treatments that are coming out, the monoclonal antibody treatments that are coming out. So those are all very exciting spaces, and things come out like literally every year for that. So I think that's an amazing moment of collaboration and progress that we can all benefit from.
I find that another thing that helps encourage successful transitions is identifying the type of transition that we want to complete. What is the goal to this transition? And I've identified a few that are pretty common. So there's a transition where it's a purely medical one, or calling it somehow, because it's mainly ruled because of insurance or training, and it's a change or a transition in providers simply because it goes from pediatric to adult care. And that's the one that most people think about when they talk about transition. But transitions in care include also a transition in the care approach. So when your condition or disease progresses or a different process occurs, your approach to care could change. We have to understand that that is a transition as well, and that can include new treatments or new equipment or new people in the team, right? Including new specialists in the multidisciplinary approach. There's also a transition that comes up, especially Dr. Postus was mentioning the 14, 15, 16-year-olds, that adolescent care. And I think it's a perfect opportunity to consider that beyond the medical care transition, there's also a decision-making transition. So it's an opportunity to teach these teams to start making decisions oriented to their specific health care needs. And then there's also a little bit more maybe objective or straightforward transition, that it's when you start needing some type of medical equipment or assistive technology. And some people just take it for granted because, I can't walk, so I need a wheelchair. And it's not just that. You need to understand what equipment you're transitioning into and what do you want to accomplish with that transition. Because it's not the same to get a wheelchair just because, I need to move around the house to be able to do some self-care chores, that I need a wheelchair to, go to college and work independently. So those are some types of transitions that I think we overlook when we talk about transitions, because sometimes we focus only on just like, the care approach, like the medical care. And there's a lot of other things that can help us move along. And so the patient doesn't feel like, it's just a concern of me getting worse or surviving whatever diagnosis I have. It's a matter of, transitioning your lifestyle to keep being productive.
Perfect. And so are there other areas we can apply the goal-oriented approach to? We talked about medical, social, educational group, day programs. There's a lot of stuff packed into transitions.
Yes, of course. I think lifestyle is also something that we overlook. Sometimes what we get when we're going through a specific condition or a specific diagnosis or a specific change due to a diagnosis, we tend to focus only on the patient. And sometimes we need to understand that a change in care for the patient can imply a change in the family's lifestyle. Because, you might need to go to more appointments, or you might need to be ready for a specific, I need a treatment or a medication at specific times, or a process I need to do every day at a certain time that, we can't go to the soccer game because at that time he needs, I don't know, an infusion or a scan, or, it's a wide area. But I think there's another thing that's very important to consider in transitions in care. The changing lifestyle that we have to do, it's not just the patient. It affects the caregiver, your surroundings, the community, whatever you want to keep doing. Whether you're studying or working or, what entertaining yourself. What can you do, or how can you do it now? I think I always think of this, like, for example, here we had a local initiative begin not so long ago about children with autistic or Asperger diagnosis, and specific days where they could go to the movies with, not a dark room, not so loud sounds. So those are little inclusion details that we might have to consider in our lifestyle according to the changes in the healthcare approach.
Okay, so I would like to ask this. Do you guys, any of the panelists, do you have any thoughts on when a patient shouldn't transition to adult care, when maybe they're better off staying over on the pediatric side?
I think in my experience, if there's a lot of ongoing medical management that is in flux, that is definitely not a good time to transition anyone to a new practitioner. I think families and children, young adults, were not, I think everybody has to be on board for the transition, meaning that even if someone is medically stable, so to speak, for the transition, for a transition to a new provider, that doesn't necessarily mean that there are other factors like Dr. Sanchez mentioned, that need to be squared away before the transition. For example, if a family's in the middle of moving, or if they're in the middle of acquiring a set of equipment from an insurance and needing insurance approval, and even if all of the medications are, those check boxes are checked and there are no surgeries on the horizon, and all of these things need to be checked off. It really has to be a almost total stability if that's possible, but things have to be as stable as possible in order for a transition to a new provider to take place. And as I say this, I'm sure many people are thinking, when does that ever happen? And I think that highlights that a transition isn't, it's not a switch that you throw, right? So it has to be a longitudinal process such that bits of it are happening over time. So maybe you identify a provider who is local and able to take over the vast majority of medical care, and maybe that's the person's primary care provider. They're transitioning to an internal medicine primary care provider, and you're slowly handing over some of the features of your multidisciplinary clinic that maybe your colleagues have been managing, but those are slowly getting transitioned over to the internal medicine provider. And maybe the last bit, let's say, happens to be neurologic care, and it's taking some time to find that person, but in the interim, part of the transition has happened to the primary care provider, who's now the coordinator of care for that family and for that patient. And sometimes transitions take years, and I think that's a feature of a good transition. I think if you can identify Tuesday was the day we transitioned to adult care, I think that's kind of a problem. I think it should be pretty smooth and seamless, and that requires either a magical period of total stability, or which sometimes happens. Sometimes families come to clinic and they say, okay, I'm ready to move on. I feel like everything's all set, and that's great when that happens. Or more often, much more often, it requires a longitudinal process. And I think I think pediatric practitioners are quick to point the finger at adult practitioners who, just don't want to take our patients, but we're not. We need to step up and start interacting with the full, with not just the neurologists that might take over, but the full spectrum of practitioners who might take over care on a period of years.
Yeah, you guys really are sometimes our medical home. So that switch is important.
Yeah, I'll sort of say too that sometimes that concept of the pediatric neurologist being the medical home or the medical quarterback, it is daunting to try to do everything that y'all do. It's a Herculean effort. So trying to break some of that up, as you mentioned, to the PCP, to the physical medicine and rehab doctor for like assistive devices, to the doctor of physical therapy, to a registered dietitian, to home health nurse coordinator, to a case manager. Those are the different kind of folks that could be part of the healthcare environment that could help for a successful transition. And again, doesn't have to happen overnight, can happen over years, and can happen with back and forth communication between the adult and the peds neuro people. I think that's very reasonable. That may be a marker of success.
I also think some of that daunting nature is, I mean, the idea of change is change. I think the word fear, we can't get away from that when we're talking about change. I think a lack of exposure to different disease processes, different patient populations, that can also provoke fear. And from the child neurology side, I think being less trained in management of adult onset neurologic disorders is one of the reasons where we feel this kind of fear-driven urgency of transitioning our patients maybe at that magical age of 18. But with that said, I think you bring up an important point that it can be really daunting to take on what a multidisciplinary care child neurology clinic might take on for a person and their family. And I want to go back to the education comment I made earlier. I think that when we're in peds neurology training, are involved in these multidisciplinary care clinics and that's normal to us. That's just what we do. I think when for the adult neurology portion, adult neurologists have to train in child neurology. And I think when they do so, they learn, they work with babies and they work with young children. And I wonder if a portion of that could be more exposure to our multidisciplinary care clinics with our older kids and young adults. And if that could be a more explicit requirement in adult neurology training as counting as child neurology training. Although I love it. I love examining a baby with an adult neurology resident. I think that's really cool. But when is that adult neurology resident going to examine babies as a part of their career? And I wonder if transitions and working in these clinics that do a million different things and kind of seeing what that entails could be more of a focus up front for adult neurology training.
I think that's a great idea. We have a pediatric neurology clinic that all of the residents that I work with go to, but we also have an adolescent adolescent Tourette's clinic, and we have a Huntington's clinic, which has a spectrum of ages, including folks who have strong family history and will probably develop Huntington's at some point in their lives, but you're seeing them as teenagers and as kids, and you're kind of doing the motor and pre-psychiatric symptom counseling. So, I mean, I almost wish, and maybe we should count that as part of the pediatric neurology training for our adult neurology residents.
Agreed.
You're making the wheels turn. Thank you.
Okay. Okay, so I guess I can ask you guys this. Is the solution to transition of care more neurologist? Or
I feel like I need.
Go ahead.
I feel like I need to jump in there. So my answer is no.
Yes,
I would actually advocate for other professionals rather than just doctors, because as I mentioned before, I understand. And I don't know most of those things that have to do with care and transitioning and understanding symptoms and the management of a medical diagnosis. But there's so many other things that we need to take into consideration, and my experience is that they're heavily overlooked. And the result to that, at least in my experience, leads to a lot of overprotective parents. And I don't mean it in a bad sense. I don't think they do it on purpose, but it feels like there's not a transition. There's nobody guiding. How do I transition that decision-making idea from what I know and what I've studied since the day I found out my kid needed some assistance to this is what you need to ask about. I receive way too many 13, 14, 15-year-olds that don't even know what their diagnosis is called. They have no idea what their prognosis is. They have no idea what the care looks like. You have them in your office and you ask them a question about their care, and they turn sideways to, mom can answer that. I don't expect doctors to hand off all decision making or just give it to them, but just like they were mentioning about the training, and it's just not adults and babies. There's like a middle ground there. And I also, the patients that are interested, that somehow parents have tried to do that on their own. There's a lot of, the most common complaint is, but I go to the doctor's office and they don't talk to me. They talk to my mom or they talk to my dad. It's including them in that conversation, not making them do all the decisions, but starting to talk to them, asking them. I think it's again, it's not a bad thing. You come into a doctor's office and mom and dad are like, so this new happened. This I've been noticing for the last week. Ask the kid. They know what's going on, and they need to. It's a communication thing, right? We need to help them start addressing, how do I communicate what I've noticed? What is changing? What is not changing? What is working? What is not working? And from my point of view and from my line of work, I think there's a lot missing there. Not to underestimate medical care, but that extra social factor, that extra
Social.
understanding of everything else besides healthcare that goes on. Sometimes something as simple as nutrition, which is not exactly a social science per se, but those little lifestyle changes that might mean the difference between more complicated treatment or something that we can work as a transition or as a process rather than we need to solve this problem right now.
So do you think that if there was more, maybe even funding, should I say, from a billing perspective for social workers? I mean, are those the people we need to be trying to get in here to fill these gaps? Is it palliative care as well? Maybe there's room for everybody, but I really feel it's hard. It's hard to get social workers even into multidisciplinary care clinics because they cannot bill for them.
Yeah, so most insurances don't. No social workers, no psychologists, no. So as a psychologist, I can tell you my main problem with billing is that billing requires that I give you a diagnosis, and you might not have one. I just need to assist you in this process, in understanding how to talk about it, in managing your emotions about these changes. And I don't need to diagnose you for that. So when you talk about these other factors, it's difficult billing because we can't necessarily put a name to it. So what your kid needs from me is not what somebody else's kid needs from me. So I can't bill the same thing. So that is a technical issue. But I also think it's a training issue. I think there's still a very wide gray area on how Dr. Buma and how Dr. Postus were mentioning. There's expectations for example, child neurologists to be the overseer, the coordinator, and they don't have to do it all by themselves. But that's the training, that's what's technically expected from them because there's nobody else doing them, and they're the ones who oversee the whole diagnosis, so they're able to identify it. So having other people from the get-go, not just in transition, from earlier care included in this team, it's something that I believe it would help.
I'm going to pause for just a second, and I'm going to, Pat Lang, would you
Yes.
like to unmute?
Yes,
Terrific.
I just unmuted. Thank you. Thank you. I come today as a parent of a child with a neurological disease, a very rare genetic illness, who's had 2 bone marrow transplants and has outlived all expectations, which is probably a lot of the reason people don't know, because most kids have not made it this far. But I also come from the perspective of I work for a nonprofit where I get these calls from families, and transition is an ugly word for so many of us. When I went out, and I don't mean that as a criticism to any of you all. I love this format. I love what you guys are doing. I thank you for it. But it's not only is it scary when you go from a pediatric facility where everybody is in the same place. So all 23 people that I get to see are in that area and know of her and know that this is a pediatric illness. The adult version of this illness is totally different. And so when I went out to make calls to say, pulmonology, would you take me? Nope, 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 too hard, too complicated. She's on a vent, she's on a trach. When I went to neurology, I was so lucky because we accidentally met somebody early on. And at the time he was pediatric, but now he's also doing adult. So luckily he is the safest person in our relationship right now, in the sense that he knows, he's seen it, he knows her, he cares about her, and that's a huge deal, as you know. One of the attempts on the nonprofit side that you alluded to about training, and I love that. One of the things that we're doing in our nonprofit, and they've been doing it for a while, is we take residents and we match them up with families. And that relationship, we introduce them and we say, you guys meet, decide what you want the relationship to be, the visit, and you get to go to their house or in the community or whatever with them. Because of my involvement with that, 2 medical students came to me 2 years ago and said, we heard about that. Can we do it? So we now have another program with medical students, thanks to these 2 students. And we had 24 medical students with all they got on their plate who are matched up with families for 1 year. And that means they can go to their home, they can go to doctor's appointments, to birthday parties, whatever it is. But I think that's a huge step in seeing a disease that they never saw before in many cases, because these are kids and they, up to adolescence. I had a potluck at my house because I just thought the more people I can get to learn. And our bone marrow, I asked the young kids to invite old fart, I'm sorry, already in practice to come. And I had bone marrow transplant docs that came that have known us for a long time, and they were all blown away with what they saw in the home and how we have to figure out how to do that. So I just think there's training. I think families should be involved to help, because families are scared and sad and it's hard. Sorry.
It's okay. Thank you for your input, Pat. Audrey Vernick, would you like to unmute? Hello.
Sure. So I am the one Claire mentioned. I work with the Brain Recovery Project, Childhood Epilepsy Surgery Foundation, and we just launched a guide and a course on children with neurological conditions and transition. And one thing I just want to mention is clinicians can also be aware that the IEP is a place where some of these skills can be developed, and there's actually an obligation by the school to do this. And I think sometimes, it's like we're siloed in these different, it's like school and hospital and whatnot, but knowing and educating the families and how to ask for that. And it's obvious for something like diabetes, right? The kid's going to go in and learn how to take their own glucose levels by the time they're 14 or 15. But this can also happen for children with more complex neurological conditions, where they learn even complex conditions. They might need a cheat sheet at first, that sort of thing. There can be IEP goals around it. It could be things like, do you know who to talk to when you're sad? Like, do you have the emotional support? Because these kids are, if they're transitioning to adulthood and they're not getting any training in that, that's scary. And it shouldn't be entirely up to the parents or entirely up to the clinicians. The school has a role to play as well. So I just wanted to mention that. I talk about that a lot in the guide that we did, that Claire shared the link. Thank you.
Thank you.
I think that's a good point. Thank you, Audrey, for bringing that up. I'm going to harken back to sort of my very narrow practice space of kind of concussions and head injuries, traumatic brain injuries. A lot of these patients come in, they're in school, they're trying to study for midterms or finals or whatever, they get bumped in the head. Football season's always in the fall, it leads into the winter, these kids' grades and GPAs start to drop, they start having problems. So I'll frequently write things that eventually have to either turn into IEPs or 504 plans or some sort of academic accommodation. So, getting back to what Dr. Sanchez was talking about, it's not just throwing pills at a problem, it's not just getting an assistive device at a problem, it's not just, talking between the clinicians and the parents. It's getting school involved, it's getting friends involved, it's getting these kids not to feel like they're on an island by themselves, totally ostracized and extricated from, their friend group, their what they would normally do on a Friday night. I'll frankly say, look, I'm shutting your life down. Like, I'm telling you can't go to homecoming. I'm telling you can't go to cheer for your team because there's too many lights, there's too many sounds, and that sucks. But we have to work through this together, and we're going to rehab you, and we're going to get you better. And it's not forever, so it's setting goals and expectations. And look, I know concussion is not the most severe, terrible thing that a pediatric patient can go through, but I see how sad and upset a lot of these kids get, and I do see how upset some of these families get with regards to how long it takes to get better. So yeah, all of these points are fabulous points.
I love it. I'm very excited about this community involvement, and I agree completely. I actually ended up working as a school psychologist in this whole pandemic. I again, and what Audrey was mentioning about IEPs, I think that's a great resource that is very, very much underused by clinicians, mostly because there's absolutely no communication between the school and the healthcare team. And I think that's one of the things that we need to get better at when talking about transitions, is involving the sports team coach and his decisions, the decisions academically, the decisions in entertainment, all that. Eventually, if we all work together, it shines to a better outcome. Also, I want to go back to what Pat mentioned, because I think it's something that I see currently with this new advances in science. We're seeing a lot of rare diseases or conditions that maybe there was never ever any training in the adult version of it, because it was just not expected. So nobody's reading about it, nobody's treated it, because it's in itself rare, and now it's getting to a point where nobody's ever seen it before. So I like to come back to that and talk about what you guys as the medical team, what you have to say about that, because to me it happens all the time. Social aspects are a little easier because it comes down to picking you out from the rare disease thing, and it can go into more of a macro thing. But when it's healthcare and it's something you haven't seen, it's not out there because nobody expected it to go that far. How do we manage that transition when nothing's been written on that transition, because so few people got there?
I think I'm forgetting who said it. I think it was Amanda. I think that there's this view that once you're someone's physician, you know everything about what's going on with that patient and their disease process. And I'm at a tertiary care center in a subspecialty clinic. I'm pediatric movement disorders. And I will say every clinic, I see a child with a really rare disease that I don't know that much about. And as a pediatric practitioner, I think we're very used to that, particularly at an academic center where we get referrals from far and wide. And I think what Amanda said, being open, using the words, I don't know. I think Dr. Postus may have said something about this as well. I think that it's valuable to acknowledge that, but then to also say, what are the parts of this disease process that I do know? So I may not know what the name of this gene entails across the lifespan, because maybe nobody knows, maybe that literature is really lacking, but let's focus on what your goals are for this visit, what the patient's goals are, what the family's goals are, what are the problems that you're facing, how can I address those problems? And if you break it down into a goal-oriented process and say, these are the things that you need addressed, I can address these things, and together we and the field will learn about this disease process over time. And we do that in child neurology a lot. There are a lot of rare diseases that maybe fall into a disease category, but that specific disease process, the field may not know that much about. But you break it down into its component parts, and you talk with the family about what their goals are, and addressing those goals. I find that a lot of those times those goals are aligned with the disease process affects those goals, but the goals aren't, they're not dependent on the disease process, if that makes sense. Those goals can be satisfied separate from the gene name that caused them. So I think thinking about acknowledging what you know and what you don't know, being willing to learn as the field learns, as the family learns, and acknowledging that you're learning, and then at the same time acknowledging what you do know, and then focusing on that in a goal-oriented fashion can be really valuable.
Yeah, I honestly think even being deep into pediatric care for the last 16 years, sometimes, even I would leave wondering what was the goal? What goal did we solve here? And, over time, people have gotten better about, putting them goals in aftercare notes and things of that nature. And I think that's a good, that's a good thing in the pediatric world to get maybe us more inclined and goal oriented. So when we move on to the adult world, we're a little bit better at working with.
I think goal-oriented care, this is a little bit, this is transitions included, but across the board, I think that should be standard of care, particularly for chronic disease processes. I start every visit with, what are your goals for this visit? What are your goals for your child? And if the child is old enough, I ask them, what are your goals for today? And because the rest of the visit, I will say, I've been doing this for a little while now, and still shocks me how often my idea of what the family's goal is and what the child's goal is not actually what their goal is. And so if we spend the whole visit worrying about what I'm worried about, at the end of the visit, we haven't addressed what's actually functionally the most important thing for the family and the child. So I think I think the start of every visit, at least I start every visit that way. And I think thinking about things, as you said, Amanda, that way from the get-go can really help set goals for the long term and the long run. I totally agree with that.
Well, maybe even teasing out what we don't know as caretakers or patients. Like, I think sometimes that's where the communication gets misaligned, is maybe there's language that's being used or some kind of a barrier where a family might not be willing to say, like, I don't understand what you just asked me. They just kind of nod and go along with it. And so, I think there's a lot of, it was perfect to hear you say, I don't want to focus on what I'm worried about this whole time. That gets to the heart, I think, of a lot of problems of, misaligned clinical care.
Yeah, I agree. I thought that was really powerful. Being able to help your patients acknowledge, and they need to learn to voice. Why are you here? Are you just, because you're not just here because I told you needed to come in. You need to understand why you come to me, not just because I tell you, come back in 3 weeks or in 4 months. There's got to be a point to you coming, and sometimes I think we need to guide them into that. They don't know. They just come because somebody told me I needed to come. And if I don't tell you need to come back, you won't. And that's how transitions get lost, because I just never follow up on them. I didn't know I had to. So I kudos to that. I thought that was really powerful.
Yeah. Okay, you guys, we're getting close to the top of the hour. So if you don't mind, I think I would like to wrap it up with one last question. What would each of you tell a family going through transition right now? My daughter's getting close to 16. I'm starting to put some plans in place. I'm thinking about a lot of things, and maybe what's some advice you have for me?
I would say start talking about it, bring it up at your visits, acknowledge the hesitancy and the fear that may be associated with the process, and start asking questions about what to expect. Because it sounds like, you have a great setup and a great care program, but I think that for some families, bringing it up may be the first time. It may trigger their care provider to start thinking about it as well. And I think having those discussions and initiating those discussions can be really valuable before it has to be done, if there is a deadline in place.
Great.
I'll echo that remark. I think definitely in this more connected digital age, I know, for example, like the Child Neurology Foundation and the American Academy of Neurology, there's a lot of back and forth between the two professional societies. So if we need to reach out to each other and coordinate, within the same city or within the same state or within the same, geographic regional area, if there's a pediatric headache specialist in the Gulf Coast that wants to send me one of their complex patients and have me take over, they can reach out to me. Or if I have somebody who I see like reams of paper and I'm like, well, I need to really get to the actual truth of something buried in 400 pages of medical records, I'd rather hear it from someone rather than try to divine a small novel. So having that one-on-one communication with another healthcare professional, another physician, is going to be a critical part of success here. So definitely for a family member saying, do you know someone, do you have a connection to someone who could help me on my next step? Or what should I expect? Is some, like, maybe a gentle nudge to them and say, hey, reach out to your colleagues, your professional alliances. And if maybe they don't know an adult neurologist who may take over, they may know an adult physiatrist or adult geneticist or someone who can help.
I would summarize my recommendation in 3 points. The first one is to be ready to accept and acknowledge that, like Dr. Luma said, it's not a switch you turn on and off. Transitions are a process. The next thing that's very important to me is to establish goals. Just echoing what we've been talking about, establish that, yes, you might need to go through a transition because there's a deadline or because it's expected, but what exactly do you want to accomplish with the transition? What are we going to get from it? And then last but not least, to build a community. Don't be afraid to ask. Most multidisciplinary centers already have checklists, already have, patients that have gone through transitions. So be willing to ask and not only limited to what you might need in healthcare, but also acknowledge that transitions might need community involvement in other areas. So you might need an extra support to help you in the decision-making process because transition can come with difficult decisions and it might be up to you, but you might need that support, not for somebody to make the decision, but to be there for you for the decision. You might need support from the school community if it affects coming in or establishing a new timeline. So that's what I would tell you. Accept it's a process. Don't be afraid of building a community based on your needs, and make sure you have clear goals to it.
All right, terrific. I honestly think community is a really big piece of it that doesn't get talked about because we really lose our big community in this transition too. So thank you, everyone. I've had a lot of fun. I believe that Katie is going to come back on.
Yep, I am here. All right, thank you so much.
Thank you, Katie.
And I'll take it away. Thank you to Amanda and our panelists for their expertise on behalf of CNF and our communities. We're so grateful that you've shared with us your time, and we look forward to implementing what we learned tonight. So as a quick reminder, CNF and our partners have more resources on transitions of care. If you've been watching the chat, there's a lot going on in there. Feel free to go check out our password protected hub where we have accessed the Zoom link for this talk, and soon you'll be receiving an email thanking you for attending. That will include a brief survey about this event. Please fill it out if you have time. We truly appreciate your feedback. It's invaluable in helping us figure out our priorities for our future programming and events like this. We'd also like to thank our partners, Acadia, Biogen, Eisai, Genentech, Greenwich, and Zogenix. And we again invite you to fund our programming if you're available. The link was shared in the chat for donation. There's also plenty more summit to attend. So we're going through Thursday of next week. Please join us tomorrow, Thursday, June 17th at 7 p.m. Eastern time for our upcoming talk. It's called Using Social Media to Build Community and Advocate for Better Care as a Young Adult. So with that, thank you again for joining us tonight. Thank you to our speakers, and hopefully we will see you tomorrow.
Thank you.
Bye-bye.
Thanks, everyone. Have a great evening.